May I ask for my participation here? So my talk is 7:05 to 7:45, and then the panel is, do I stay after the panel is over, or is that just for your internal meeting?
No, no, I think you're very welcome to and be there at the panel discussion.
Yeah, but
If you
after
can.
the panel discussion, the 8:25, after it says 8 to 8:20. Ah, I see. I will, okay, I misunderstood here. All right, so I stayed until 8:25. Perfect.
If you could, yes, thank you.
Yeah, yeah, sure, of course.
Okay, I think it's 6:45 here. We'll get started. Okay. Good evening, everyone. Welcome to the first SingHealth Duke-NUS Blood Cancer Center webinar on multiple myeloma. Thank you very much for choosing to tune in and spend the time virtually with us this evening. I'm Dr. Chandramouli Nagarajan, consultant hematologist at SingHealth Duke-NUS Blood Cancer Center and Singapore General Hospital. In fact, the last few days have been quite a few webinars on multiple myeloma, and I can see that lots of you may have a webinar fatigue. However, be rest assured that this evening's program will be well worth your while. We're going to have a very practical and practice-based discussion on the management of multiple myeloma. The first talk would be on high-risk multiple myeloma, be given by Dr. Chen Yunsen, giving a local perspective, followed by management of high-risk multiple myeloma by none other than Professor Ola Landgren, who has joined us quite early this morning for you, evening for us. Thank you very much, Professor Ola Landgren.
Thank you for having me.
Now, I have a few practice points before we dive in. As we all know, this is September is Blood Cancer Awareness Month. And it's quite timely that we have this webinar today. Today's webinar is being recorded, and you'll be able to download them and watch the content at your leisure once we have finalized the recorded content. So you can email the request for the link to the webinar in due course to Rena. You will all have a Q&A chat box at the bottom of your screens. So do ask those questions via the Q&A chat box. If you're not able to take the Q&As within the designated Q&A session, we might be able to pick it up on the panel discussion. Lastly, you will all receive a feedback form at the end of the webinar. Please do fill it in so that it would help us improve our future webinars and content. This webinar is sponsored with an educational grant from Amgen, but the content was entirely ours and they had no role to play in what we decided to talk about today. This educational material is intended to provide information on research activities and may refer to products not approved for use in Singapore and or unapproved use of products approved in Singapore. The views expressed in this presentation are exclusively those of the presenters and panel members. Amgen Singapore does not endorse the promotion of unapproved products or indications. So that now out of the way, we'll dive into the session directly. The first session would be by Dr. Chen Yunsen. She needs no introduction for members from Singapore, but by way of introduction for our overseas audience as well, Dr. Chen is a friend and colleague of mine in Singapore General Hospital with a specific interest in myeloma and plasma cell disorders. She's been instrumental in getting many of the research projects in myeloma within SGH. And in fact, it so happens that she has just returned from Memorial Sloan Kettering Hospital, where Professor Ola is from, just a few months ago. She spent a year there learning on cell and gene therapy for myeloma. So without much further delay, Yunsen, do you want to go?
You can stop your sharing and all that stuff. Hi, good evening, everyone. Welcome to our SDDC talk on myeloma. And thank you, Mauli, for that kind introduction. We are very excited, Mauli and I, and on behalf of the SDBCC to have Prof. Ola here with us to learn some insights from him on the management of high-risk myeloma, which is a unmet need in Singapore, actually, because until now, we don't really have a very good treatment for this subgroup, especially in Singapore, where most of our patients are under subsidized care. So like Mauli, I practice in Singapore General Hospital. We see a number of myeloma patients, and today I'll be sharing some insights on what we have been doing to try and help this group of patients do better. So as we know, in multiple myeloma, in plasma cells, the normal differentiation, they come from terminally differentiated plasma cell, B cells. They undergo somatic hypermutation, class switch recombination to generate a polyclonal clone. And in order to do this, the antibodies secreted are polyclonal to give rise to a very healthy immune repertoire. However, in multiple myeloma, the plasma cells itself, they rise from a single clone. Because of this, they lead to immunopoiesis, whereby the antibodies secreted are monoclonal. As the defect arises from the somatic hypermutation and class switch recombination, we can see that there is a varied amount of genetic defects that can give rise to multiple myeloma. Usually they start off with primary genetic defects such as hyperdiploidy or translocations such as 414, 1114, 1416. Subsequently, as they go through different kinds of treatment, they may carry secondary genetic events such as monosomies or amplification of 1q21, or pick up other genetic alterations along the way. As such, the myeloma clone itself can be very heterogeneous and give rise to a very varied kind of clinical presentation. We know that there are differences in many of our myeloma patients. Some patients, by some risk stratification, if they belong to RISS1, they can have a good course of disease and respond very well to initial therapy. In today's days and age, with the multiple different lines of treatment, they might go on to survive more than 5 years in general. However, there are groups whereby they are considered high risk. And in this subgroup, generally, they progress within 2 years. And in fact, this population is the one we want to focus on today. So the high-risk group of myeloma patient is an unmet need. They have usually mortality within 3 to 4 years due to progression of disease and have developed often rapid development of drug resistance upfront. There are many different kinds of definitions of high-risk myeloma, but in general, high-risk chromosome abnormalities are defined by IFISH, such as deletion 17p, 414 translocation, 1416 translocation. The MSMART guidelines defined by Mayo itself actually included 1q21 amplification into their newest high-risk subclassification. And this population actually contribute up to about 25% of patients who are newly diagnosed with multiple myeloma. Beyond genetic classifications, there are also clinical features which constitute high-risk features, such as extraosseous extramedullary disease, plasma cell leukemia, central nervous system involvement, circulating tumor cells, or high LDH. We know very well that this can help with prognostication of myeloma. However, we are uncertain whether we have reached a stage where, because of these high-risk features, there is a role for risk-adapted therapy, and this is something we want to explore more today. If we look at the evolution of myeloma treatment, we are all quite happy in the fact that the newer treatments can help myeloma patients do better overall. In SGH, this is our trend of diseases on our disease registries. Over the last 20, 30 years, we do see an improvement in survival. Up to 2 decades ago, our median survival was only about 3 years. But along with time, in the last decade or so, this has gone up to about 5 years. We do hope that this curve continues to improve over the years. However, as we go and subdivide our patients into non-high risk versus high risk, we do find that our improvement in survival is actually mostly seen in our non-high risk patients, as can be seen on the survival curve over the left. In our non-high risk patients with improvement in our treatment regimens, over the last 2 decades or so, the survival has improved from about 3 years to up to over 8 years in the non-high risk cohort. However, if we look at our high risk patients, there is not much improvement despite the improvement in treatment therapies. Of course, because this cohort of our registry patients go back many years, the high risk definition in this case includes patients who were ISS3, IFISH3 or RISS3 because we did not have FISH maybe 20, 30 years ago. So then it brings us to a point of how then can we do better for our high-risk myeloma patients. I think one of the ways whereby we feel that we can help our high-risk patients is to optimize upfront treatment. And there are many ongoing trials in myeloma patients, whereby we do see an improvement in the survival. A lot of these are with the addition of monoclonal antibodies to what we traditionally use as a backbone, which is a proteasome inhibitor-based backbone. And there are a couple of trials that have demonstrated very good results, although it is not an exclusively high-risk population, such as the Cassiopeia trial and the Griffin trial in transplant-eligible myeloma patients, whereby daratumumab is added onto backbones such as VTD or VRDs. In the non-transplant eligible patients, adding daratumumab to regimens such as VMP, PCD also helped improve survival. Another way we can look at it is in a non-transplant eligible subgroup, whereby adding on daratumumab to the lenalidomide dexamethasone backbone also helped to improve responses. Beyond the addition of monoclonal antibodies, some of us are also looking at using better proteasome inhibitors to improve the effect, to improve efficacy and help patients in terms of myeloma. And for this, the Endurance trial tested KRD versus VRD. Beyond optimizing upfront treatments, we can also improve outcomes for transplant-eligible patients by considering things such as tandem autologous stem cell transplants, or in very high-risk patients, even considering the role of allogenic transplants in this patient. I think beyond this, over the last few years, we see more and more focus on achieving MRD through the use of consolidation and maintenance therapy, and also the use of additional targets such as a whole plethora of anti-BCMA agents, targeting ISLAMF7, etc. So then as we look in myeloma, we know that MRD is a predictor for long-term improvement in outcomes. So one example is in the Cassiopeia trial, whereby the post-consolidation MRD in the high-risk subgroup is significantly increased in the patients treated with daratumumab on top of a traditional VTD. And because achievement of MRD negativity rates predict survival, so we could postulate that this might mean better outcomes for high-risk patients through the use of the addition of agents such as daratumumab. Beyond the transplant-eligible group, we see in the LSI-1 trial, the addition of daratumumab to VMP helped to also improve survival. And if we looked at the subgroup analysis in the patients who were actually ISS3, there was a trend towards improvement in outcomes in the patients who were treated with daratumumab on top of VMP. However, this was not really seen in the patients who were actually had a high-risk cytogenetic profile at trial entry. This is actually from the POLAC study rather than the Maya study. What we see is that when we did do some subgroup analysis, comparing high risk versus non-high risk, the treatments by adding daratumumab actually helped to improve survival in the high-risk subgroups. However, what we actually want to do is not just to improve outcomes in these patients, but to overcome the adverse risk contributed by these high-risk adversities. So we hope that one day we can see these therapies actually bring up the curve such that the survival of our patients with high-risk abnormalities reach that of the standard risk patients. If we were to look at the Endurance trial, whereby KRD is compared with VRD in myeloma patients with no intention for early stem cell transplant, we do see that there is no difference between KRD and VRD. But this does not mean that the changing of Velcade to a second-generation proteasome inhibitor does not benefit high-risk patients, because in this trial, patients with high-risk features such as p53 deletion, translocation 14-16, translocation, they are all excluded from the trial. And we know that these are the group of patients who benefit the most from second-generation proteasome inhibitors. If we were to look at our Singapore healthcare model and how we can use some of these results to help our patients, we do find that about 70 to 80% of our Singapore patients are actually treated in the public sector. What this means is that they derive funding from a mixture of state subsidies, compulsory savings, healthcare insurance, and they actually have to co-pay. The implications of therapy is that upfront use of monoclonal antibody, or actually more than one novel agents, even something like first-generation bortezomib with lenalidomide, followed by maintenance, is actually unaffordable for most patients. Bearing this in mind and knowing that most of our myeloma patients go through this type of clinical course, we are always trying to find something whereby we can bring our patients to deep, long-lasting MRD negative remissions. And beyond this, we want the treatment to be efficacious, tolerable, and also affordable. and hopefully the patients have no treatment-related toxicities. With this in mind, the SGH-MM1 trial was conceived maybe about 5 to 6 years ago. Here we were looking more into giving our patients effective as well as affordable treatment. And we studied the use of carfilzomib, cyclophosphamide, and dexamethasone as frontline treatment for transplant-eligible patients with high-risk features. For this trial, we gave our patients the combination of case ID for 6 cycles, and we aim for stem cell collection at the 4th to 6th cycle. After completion of 6 cycles of case ID, we transplanted these patients with high-dose melphalan. Once they recovered their counts, we gave them 2 more consolidation cycles with carfilzomib, cyclophosphamide, and dexamethasone. This was done in the era whereby we do not maintain all, whereby there was no definitive evidence to maintain all our patients. So for this trial, MRD assessment was done after completion of 6 induction cycles of case ID, transplant, and 2 further cycles of consolidation case ID. Thereafter, those patients who were MRD negative were actually just follow up, whereas those who were MRD positive were given a further 2 years of carfilzomib maintenance. We defined high-risk features in this study as patients who were either ISS3 or had adverse cytogenetics, or such as translocation 414, translocation 1416, or P53 deletion. This was run over a period of, we recruited patients over a period of about 3 years, and we recruited 30 patients with our sister institution, NUH, and we last did our analysis in about May this year. So our patient had a good median follow-up of 43.4 months. So in terms of where the patients were in terms of treatment, we treated 30 patients with high-risk multiple myeloma. After 6 cycles of induction, there were about 3 patients who were withdrawn from studies due to early side effects, such as thrombotic microangiopathy, acute pulmonary edema, and STAT9. There was 2 patients who had very aggressive disease, and they actually progressed during the induction itself. We managed to transplant 23 of these patients, and 1 patient progressed soon after transplant. Amongst the 22 patients whom we actually completed consolidation therapy, about half of them, 9 of these 21 patients were actually MRD negative, and they were observed expectantly. The other 12 patients who were not MRD received carfilzomib maintenance for about 2 years. So in this population, we found that our progression-free survival, even in these very high-risk patients treated with case ID, was up to 40.3 months. If you were to look at the patients who were RISS3 with a median progression-free survival of about 29 months, this was actually quite a stark improvement. And most of our patients, their OS was not reached at a median follow-up of 43.3 months. In terms of response rates, for our patient who reached the post-consolidation stage, we actually achieved MRD negativity in about 42.9% of the patients. And the majority of them actually did achieve complete remission. In the whole cohort, by intention to treat, the best response was about 60% of patients actually did achieve complete remission. And MRD negativity was seen in 33.3% of patients. So if we were to look at our patients according to MRD status, of course, the patients who achieved MRD negativity did far better than those who did not, with a median progression-free survival of 41.3 months. So patients who actually attained MRD negativity had improved outcomes. And we were quite pleased that treatment with case ID actually helped a good number of patients with high-risk genetics at presentation to achieve this status. If you remember, after consolidation, we were able to determine MRD status in our patients. Those who were MRD positive received 2 further years of carfilzomib maintenance. By doing this, we actually were able to help these patients attain a good progression-free survival as well. And their progression-free survival matched that who were MRD negative. It also leads us to wonder whether, well, if we were to give maintenance to our MRD negative patients, whether we further improve their survival outcomes. So we do know that our Asian patients do have a little bit more toxicities as compared to other counterparts elsewhere in the world. However, this case ID combination was quite tolerable in most of our patients. Most of the grade 3, grade 4 toxicities were hematological toxicities such as anemia, neutropenia, and cytopenias. We had a small number of patients who had severe adverse events such as acute coronary syndrome or acute pulmonary events. There were 3 patients in our local cohort who actually had thrombotic microangiopathy. However, this resolved upon cessation of carfilzomib, and we did not re-challenge these patients. Their renal function improved to baseline as well. So in our unpublished data, which we are aiming to publish soon, we found that the KSID combination is an efficacious and well-tolerated combination that did not adversely affect our ability to mobilize this patient. There was also very favorable responses, especially in those who were able to follow through with KSID induction, stem cell transplant, and KSID consolidation. Patients were also able to keep up with the carfilzomib maintenance. Amongst all our patients whom we put on the 2 years of maintenance, only 1 patient developed adverse events and had to drop out of the trial because of carfilzomib maintenance. Patients who were able to get through with this regimen, we did see a very good response rates. Up to 70% of them achieved complete remission, and we even saw patients achieving MRD negativity in up to 40% of these patients. So it leads us to wonder whether this can be a potential upfront regimen in a resource-limited setting like Singapore. Why? Because a proteasome inhibitor and immunomodulator combinations such as bortezomib, lenalidomide in the upfront setting is actually unattainable to most of our patients. Because in our local setting, the proteasome inhibitor such as bortezomib is heavily subsidized by the government. However, the addition of another novel agent such as lenalidomide in the upfront setting adds to the cost that the patients have to pay. Hence, the use of a potent proteasome inhibitor such as carfilzomib in combination with a cheaper alkylator such as cyclophosphamide can actually help our patients with high-risk features achieve very deep remissions, including a good proportion of patients who achieve MRD negativity, even when they started off with high-risk adversities. Patients who were able to follow through with KSID induction, stem cell transplant, and consolidation, we see increase in achievement of complete remission status and MRD status as they went along. In terms of maintenance with carfilzomib, we do find that in comparison with our historical cohort, bortezomib can be quite intolerable in the long run because of development of adverse events such as peripheral neuropathy. Ixazomib, on the other hand, in terms of treatment of high-risk patients, may be a little bit less potent. So the favorable survival outcomes seen in our patients placed on carfilzomib maintenance actually do provide some support for the use of carfilzomib in the long-term setting, such as in maintenance. So of course, we do not compare trial patients with off-trial patients, but this is just a little graph showing our patients treated with the trial combination of carfilzomib, cyclophosphamide, dexamethasone with our historical high-risk cohort at SGH. And we see that there is somewhat of a survival improvement in our patients treated with a second-generation proteasome inhibitor with a cheaper alkylator. So we hope that we see our myeloma patients getting here one day, whereby after a potent induction treatment, we get them into very deep, long-term MRD negative remissions without any treatment-related toxicities and being affordable such that they can continue on receiving treatment without the added financial toxicity. With that, I end my little talk about our Singapore perspective of treatment of high-risk patients. In myeloma, we are not a single person treating one patient. We have all our patients and our nursing staff to thank. I do want to give special mention to the lymphoma myeloma group at SGH, Molly being one of them, and we do have other colleagues whom we work closely with. Of course, there are many coordinators who have been helping us with our trial. We thank the other team at SGH, the SDDC team led by Dr. Ho, and our Department of Hematology led by Dr. Ng, and the transplant staff. Beyond SGH, we work closely with our Singapore myeloma study group with colleagues in the National University Hospital, such as Dr. Cheng, who is here, Dr. Darrow, who is in a private setting, and the rest of our colleagues. Thank you.
Thank you very much, Jinsen, for the great presentation. So now we can move on to the next part of the talk, the plenary talk from Dr. Langren. Dr. Langren doesn't need any introduction for people who are interested in hematology, period. Just by way of introduction, though, he started his career in Sweden as a research fellow in Karolinska Institute, And through from there, he became an attending, subsequently in National Cancer Institute, NCI. And then currently he is settled as an attending physician and the chief of myeloma service at the Memorial Sloan Kettering Hospital in New York. I went through his CV and I was so impressed with all the research work and the clinical work he has done. He's definitely an accomplished clinician scientist with an MD PhD and has got humongous amount of research under his belt. Some of the other work we might know and be familiar with some of the myeloma work that he has done, but I learned quite a few things in terms of his interest in CLL. He was involved in the phase 1 work with BTK inhibitors, for example. So there was so many things that he has done in the years gone by. And now he has reached a stage where he's been a mentor for many of the junior members of the research community from MSK, who are now becoming leaders in their own right and have many first author publications in myeloma. And so without any further delay, I would like to welcome Professor Ola Landgren to deliver his talk on management of high-risk multiple myeloma. Thank you very much, Dr. Landgren, for coming on board today and giving a lecture. Thank you.
Thank you very much for those very warm and friendly words. And thank you so much for inviting me. It's really a great honor and a great pleasure attending your program here today. It's a little bit after 7 in the morning in New York. So I have most of my day ahead of me, and I think you're in the evening. So you're, I don't know if is it 7 o'clock your time, but in the evening. So I will do my best to keep you not leaving the program here although at the end of your week. I was asked to talk about management of high-risk myeloma, and I really enjoyed the presentation by Dr. Chen, Jun Chin before me here. I really like that, and I have several questions I would like to address and ask during the Q&A session. It's striking to me that we have very similar approaches and similar thoughts to these questions. The way I put together my talk here today is to try to go actually back a little bit to some of the concepts that we use when we talk about high risk. One thing I've learned over the years is that at least my perspective, is that we kind of take a lot of things for granted and then move on. But if we really go back and look at some of the details, how the data actually was put together, sometimes we don't really bring all the details forward in time. So I will spend a little bit of time talking about some of the details behind what we refer to when we talk about things. And then I put it in context going forward. These are my disclosures. So with that kind of introduction of trying to go into details, I felt it was reasonable to start off saying, like, what is high-risk myeloma? And I think the previous talk highlighted on these things as well. But I will go back and say, to me, this is probably one of the first papers out there that kind of proposed this concept. And this is the 1975 publication in the journal Cancer, which really set the stage for what we refer to as high stage, which I think is the first kind of clinical major paper on high risk. This paper is based on a very small number of patients. It's only 71 individuals published in the journal Cancer. And there are a lot of clinical measures here. They counted the number of lesions in the skeleton. They checked the hemoglobin, the calcium, the M spike. I think all this information is simply a way to count for more disease versus less disease. And if you look up some of the early papers by Dr. Salmon, who was the senior author here, he was convinced at the time that more disease was bad. And I think that's probably true for a lot of diseases, unless you have really good therapy, because then you maybe can overcome that. So the second paper, and I apologize, I see that the reference in the bottom still is the Cancer 1975. This should actually be the JCO paper by Phil Gripe from 2005, because this is many years later. This is 30 years later, when the idea was, let's believe in more disease is worse than less disease, but try to find some clinical markers that are easier to do. And that was pooling of very many clinical trial data. There were 17 institutions that contributed more than 10,000 patients. And it was basically a data mining effort. I remember when this work was done, it was union multivariate analysis. And the winners were, as we all know, beta-2 microglobulin and albumin. And playing with different cutoffs, it was able to say, if you're below this cutoff, you're 1. If you're above the cutoff, you're 3. And if you're not 1 and 3, then let's call that 2. In 2015, 10 years after, this revised staging system, as we know, came out. And this was, again, a joint effort with 11 institutions, again, that contributed clinical trial data. And I keep on mentioning these details because we all know that patients on clinical trials are not the same patients we see in the standard of care setting. For whatever it's worth, these patients excuse me, were included. And you see here there are 4,445 newly diagnosed patients enrolled. And then all the variables for the biological features were available for over 3,000 patients. I think one of the big steps forward, if you wish, in this most recent paper is the fact that we're no longer talking about burden of the disease. We now have actually, I would say, started focusing more on the biology of the disease. And this obviously is because now stage 1 implies that you have these markers low, you have standard risk cytogenetics and normal LDH. But if you have the former stage 3, in order to stay in the category stage 3, you also must have adverse cytogenetics or high LDH. If you don't do that, then you end up in stage 2. And the reason behind this was because we all know that the therapies are getting better and better. So patients who previously were in the category 3 started having the same outcome as category 2. And that makes this whole staging system quite irrelevant. So if you cannot really discriminate patients, that's when these systems start falling apart. So it's basically refinement. But I think there is obviously much more work to be done. And I will talk about where I think the field is going and share with you some of the data that I have read up on, share my perspectives. Here we have the median overall survival for stage 1, 2, 3. I want to caution all of us that, of course, the OS is different for these different stages, but this is in the light of how these treatments were given or how these patients were treated. So if patients were published in 2015, presumably with 6 years of follow-up, they had to be at least started 6 years prior to that. So that would be 2009, and we know the data goes way back before that. So the treatments behind the scene here are not the same as we have today. And we all know that the patients with the revised IAS-3 can have a better outcome. And I think you show beautifully for the work you have done. I think the treatment you have come up with is a very good option. So if you give better combinations, you will change these curves. These are not written in stone. So that's kind of my message here. I'm also probably stating the obvious that behind the scene for the high-risk cytogenetics, if we're looking at technologies where we can look for red and green dots and count them, yellow dots, there probably is more to be learned if we have more advanced technologies. We all know these things, but just to highlight that all the literature we look at together is based on these quite old technologies, cytogenetics and FISH. These are 1980s technologies. Mayo Clinic like to publish their own guidelines, and they say that high risk, intermediate, and standard risk have difference in outcome, and the previous speaker gave some other measure on how this pans out. So where do I think and see the field going forward? I think I share the perspective with the previous speaker that I think the depth of response probably adds another dimension beyond what I have just talked about. The burden of disease, the features of the disease, also how good of a response you see in that patient. And that, I guess, comes back to how good a therapy is. And I think, to me, one of the lessons learned that is still one of the major references is this 2017 New England Journal determination study. VOD 3 cycles randomized to collection and 5 more cycles of 1 year maintenance, or after 3 cycles randomized to Melphalan 200, 2 more cycles and 1 year maintenance. And we know that the Melphalan arm is the winner. It's 50 versus 36 months of PFS, which was the primary endpoint. But we also know in this study that they have published this in the following year in the Blood Journal, showing that the reason behind the fact that the PFS is better in the transplant arm is because more patients achieve an MRD negative status in that arm. They show in this blood paper that it's around 30%, and in the non-transplant arm it's around 20%. And that is what drives this difference in PFS between the two arms. But I personally think that a more interesting forward-looking observation that they highlight very much in this blood paper is that progression-free survival is the same for patients who are MRD negative in either of the two arms. And also they highlight the fact that high-risk patients that are MRD negative have a significantly better PFS than standard risk patients who are MRD positive, which favors MRD being a stronger prognostic factor than cytogenetics. And also highlighting the fact that MRD negativity is a strong risk factor within the compartments. So MRD negativity within the standard risk patients is better outcome, and it's also true, MRD negativity is better PFS also in the high risk patients. So overall, MRD negativity seems to be a stronger factor than cytogenetics. And maybe you want to push it even more and say it may be more important if we do the new determination study that Dana-Farber is leading. They have done very similar, and they have continued maintenance. So if you have a deep response and you can keep the patient on maintenance, those results have not been published for all these years. We have all waited to see them at ASH, and they're not publishing them. We have contributed a lot of patients. So most likely those patients have not had events, because that's why you don't publish your data. So that tells us that continued maintenance after you have a deep response is probably even more important to go forward. So can prognosis even be determined at diagnosis, as was proposed back in the 70s? So it started off with the ISS, and then we have had all these iterations. Or is this something that we really need to be a little bit more patient about and look after treatment? MRD status, I did not talk about imaging, but we all know that there are a lot of additional flavors here to consider. So I then want to look at some of the trials that have stratified patient outcomes by risk status using these high-risk definitions with FISH, with all these caveats. So I thought that one way of looking at data is to use this paper in the Lancet that finally was published, the old SWOG study comparing VRD with RD, no transplantation. We all know that this is what kind of swayed those doctors that used to like 2 drugs to say, okay, 3 drugs is better. But what I want to highlight here is that the addition of the 3rd drug really made a difference for the high-risk patients. It's 38 versus 16 months. So 2 drugs is very inferior in the high-risk patients. But if you look in high-risk patients getting 3 drugs and standard risk getting 2 drugs, you could argue and say it's very similar. But the biggest winner obviously is adding the third drug to the standard risk. So I think that there are so many ways of saying it. I think you could say that if the high risk don't get the best therapy, they're going to really fare poorly. But you could also say if the standard risk patient really get the best therapy, then that's where you have the maximum positive outcome. Here we have the DRD versus RD by Fish, and there's been a lot of discussion on the role of daratumumab in high-risk settings, and there have been some more recent publications saying that it does add even in the high risk. But here we have the threshold of the confidence interval cutting through 1. So daratumumab in the high-risk setting maybe doesn't add so much. Well, that's an ongoing controversial discussion. So unlike what I said before, that if you add the 3 drugs to the standard risk, you have better outcome. And if you don't do it for the high risk, you have a really inferior outcome. What do we see in this study? This is from the New England Journal 2019 in the newly diagnosed MAIA study. So the 3-drug combination in the standard risk patients, you see progression events or deaths, they're 25%. And then you have in the high risk patients, you have 38, and standard risk for 2-drug, you have 40%. And then you have high risk with RDs is 39. So it seems to me, when I look at this, that the real benefit is in the standard risk patients. When you add daratumumab, you can reduce the number of events. But in the high risk patients, the difference between DRD and RD, at least based on these data, is the same. So adding that 3rd drug in high risk patients doesn't seem to make a huge difference here. And we can debate this, and this is just one study, and there are additional other studies that have looked into it. So the point I'm making here is that adding the proteasome inhibitor to the high risk on the previous one seems to make a big difference for both improving standard risk and to help the high risk. Here we see the antibody helps the standard risk, but for the high risk, not so much. Here we have a long-term follow-up from the NCI study that was started 11 almost years ago, looking at KRD in newly diagnosed patients stratified by high risk and standard risk. Kind of a little bit of a similar approach to the study you showed with your case ID. It's a smaller study, it's only 45 patients, but you can look at standard risk and high risk. And this study shows that with KRD, the hazard ratio for time to progression is the same for standard risk and high risk. And also this study shows that for patients in this study who achieve MRD negativity in yellow, at 60 months of follow-up, they have not yet reached their median progression-free survival. For patients who are MRD positive, you see that you cut through there. So I think what I see here, if I put all these pieces together, is that, and these are my experiences, my opinions, and you can take it for whatever it's worth. I don't have any intention to tell anyone what to do. I'm sharing with you my interpretation and read of the literature. I think what I see here is that if we use weaker drugs, we can talk about standard risk, we can talk about high risk, and we can use the current technology to assign patients to these 2 groups. But I think also what I see is when we use better drugs, is that the high risk group is a shrinking species numerically, but the people that are in this high risk group, they have an even worse outcome. And this is probably not that complicated, and I think this is probably true for most diseases we treat as physicians. I also do think that in my experience and in my opinion, that there are kind of 2 schools of thought. For the standard risk patients, you can argue for using weaker drugs or better drugs. while for high risk, most people would say we have to use the better drugs. And I think that the paradigm and the outcome here are inspired and influenced by using the weaker drugs. Is if the resources are scarce, and I guess everywhere resources are always restricted. There is no place with unlimited resources. But I think if the patient has the option to choose a better therapy, the focus could be to optimize the clinical outcomes for that standard risk group. And for the high risk, I think there is more of a requirement in order to avoid or adverse outcome for the high risk patients. And to me, these are part of the flavors that we are dealing with when we're looking at all these different studies and listen to different speakers. I think there is a lot of work that we can do and we have to do to better understand the molecular profiling of myeloma. So historically, as we heard from the previous speaker, myeloma has been split into two groups. So it's the so-called hyperdiploid and non-hyperdiploid. And the non-hyperdiploid typically refers to those patients that have an IgH translocation. So IgH partnered with certain oncogenes, MMZ and NAF genes would include mostly we see 414, 1416 and 1420, but there are other partner chromosomes and some of them are not necessarily high risk, such as cyclin D1 for 1114, and then you have 614 as well. And then there are additional recurrent chromosomes, gains and losses that have been on the list for a long time. 13q has been for a very long time, and that's probably driven by technology because people started looking for chromosome 13 deletions in other diseases, and then they started looking at myeloma, they found it, and there were debate back and forth. I don't think that really has a prognostic impact so much anymore. 1q has become more popular because there are assays allowing us to test for that, and 17p, the tumor suppressor gene, has been on the list for many cancers for many years, including myeloma. So some of these are associated with what we clinically refer to as high risk, but there are probably more details to be drilled into here. So for 14, 14, 16, and 17p. So what I refer to here, and I'm sure you guys are on top of that same literature as well, but I want to highlight on it because I think it's important, is the emerging data to suggest that the high risk can be further improved by looking at biallelic events. So similar to double hit lymphomas, we have the biallelic events in myeloma also, including, for example, TP53 and more than 3 copies of 1q, which has been recently associated with adverse outcome. And I will share some more detail on that in the coming slides. We know that the current standard of care, conventional chromosome analysis and FISH panels, or if you use SNP array, then you can detect these translocations and gains and losses. But unfortunately, with these technologies, we won't be able to take it to the next level because we cannot capture somatic point mutations. So here's data we just published in the very end of 2019 in the Blood Cancer Journal. In a nutshell, what we did was that we designed a myeloma-specific next-gen sequencing capture assay. So extracting DNA from patients with myeloma and running them on this assay allowed us to capture all the translocations because we had full coverage of the IgA locus. And we also spread baits throughout the genome so we could capture all the gains and losses we could see with SNP array or cytogenetics. And then also, because it's a DNA-based assay, we designed this assay to capture around 120 genes relevant for myeloma. So in one assay, you could get all the same information that you get from FISH, from SNP array cytogenetics, and from a capture panel if you use a somatic mutation panel. So by taking this approach, and this is published, you can look it up online, it's a lot of work. I think it's very important. It's compared head to FISH and cytogenetics, and it shows that it's more than 99% concordant specificity and sensitivity. But beyond the specificity sensitivity for FISH and cytogenetics, because you have the capture of the somatic mutations, you can now look to see how many patients actually do have these biallelic events? So we, in this cohort of 154 patients, identified 20 patients with biallelic events. And they affect TP53, FAM46C, RB1, which is 13q, as you know, and TRAF3. So if you just look specifically in the 17p deleted patients, there were 29 patients in this cohort that have 17p deletion. 13 of them, around half, had a mutation in the non-deleted allele. So there's a lot of colors and things to look at here, but on the very top you see TP53, and then you see there are something called lollipops that stick into them. Those are mutations, and then they are color-coded. And then you go on the very low part of this slide, you see there's a second panel B, and the top row there is TP53. And if there is a red box, that means that that patient had a deletion of 17p on one allele that could be picked up. And you could see that with FISH or SNP arrays if you did that. But what this assay also did was that we found a mutation of the other allele. So these are the biallelic patients. The ones that are blue only have a 17p deletion, and they lack the mutations. There were also a few patients who had mutations only, but no deletions that you wouldn't know if you didn't sequence them, obviously. So half of them are red. And here you have a paper from Brian Walker, published in Leukemia, also 2019, showing on the left PFS, on the right OS. Patient in blue are the biallelic, so they have both a mutation and a deletion. And the green and the red are superimposed. So these are patients that have monoallelic, so only a 17p deletion, but no mutation. And the green wild type, these are patients who had no 17p at all, they are wild type. So we see here that having a 17p deletion without a mutation has the same outcome as not having a 17p deletion, while having both. That's what drives the bad outcome. So different biology, and I think it's not only that we can identify them, we also need to start thinking about, we need to treat these patients differently. They need something different. I think tracking of residual disease obviously needs to be better also. What have we done at our institution? So we have developed in-house both single tube 10-color flow cytometry, and we have compared that to the older technology of Euroflow with 2 tubes. And we show in 1 tube you can deliver 10 to -5. And we also have developed in-house VDJ sequencing, so we can turn that around. We also have set up high throughput MALDI-TOF screening. If you have not done this, I really recommend you looking into this. I think this is going to change the field for sure. We have developed this in-house. We have already obtained New York State approval, and we are about to implement this as in standard of care. So with 10 microliter of serum in 10 seconds, you can screen for low fragments of these proteins in the blood. So in the blood, you can do it every time you do blood draw. We have set up sample handlers, and we hook this up into our regular robotic system in our lab department. So we would soon be able to generate high volumes of data with this. There's still a lot of work that needs to be done, a lot of kinks. Light chains don't yet work as well, so that needs to be improved. And also there's a quantitative component to it. But I think this is definitely, I think it's going to replace IFE and SPEPs, and probably light chain assays also with the conventional platforms. And you could think of this, I think, as a little bit of a halfway blood-based MRD test. It's about 100 times better than IFE. We have also played with approaches. We started in the lab. We took mice and injected myeloma cell lines. And then we took antibodies. We made our own antibodies and labeled them with zirconium. But we also decided to try just to take daratumumab because we had the intent to see if we could go into humans. So we linked this up with DFO, and then we labeled it with zirconium. We then took, on the upper left, mice where we injected OPM2 cell lines. On the upper left, you see 2 mice with that, and you see in luciferase presence of these cell lines. On the lower left, mice without OPM2 cell line. And if you move to the very right, you see after we have injected antibodies that there is uptake in the bone marrow in the upper top right mice with antibody that lights up. So, and that was not on the lower right. So we showed in mice that you can inject labeled antibodies, and you can actually detect presence of myeloma cells with an antibody. So this is an immunopet. We used this to develop a phase 1 study that was developed to, first of all, of course, determine safety, but also optimal parameters for doing it, and see if we could set up a rationale for a phase 2 study. So we didn't really know when to do imaging. The antibodies take about 5 to 7 days to penetrate all tissue in the body. And you need to have half-life that's long enough for the zirconium in order to be able to track these antibodies. So you see the same patient image day 1, day 3, day 6, and 7. So in this first series, patients were allowed to be up to 4 times. And I highlight on one of them, on the lower right, you see the antibody lighting up. In the middle, you see destruction in the bone. On the left, you see the fused images. So I don't have biopsies yet done here, but in the lower part in the middle, there is a destruction in the bone, indirectly indicating that this probably is myeloma. And you have the leg from another patient of mine, and you can use your own imagination and look and see where you think myeloma is. And here you see the antibody uptake in this patient. Here is the last patient I shared with you that was on this study, worked up with a regular FDG PET-CT, which as we all know is glucose uptake, red as negative. And 7 days later, this patient was enrolled on the study for PET-CT, for the immunopet. And this is what this patient looks like with zirconium 89. And there are very many sites, as you see, that light up. So we actually should say we are just about to open in November a phase 2 study where we're going to enroll a larger body of patients, and we're going to compare these technologies also with blood-based and bone marrow-based assays. And we also, as part of this study, are now doing image-guided biopsies of these residual sites to try to characterize the disease at these different sites. This is also available online in radiology, and it just came out, I think, 2 months ago. So we're very excited about this. Modern treatment strategies, I do think, build on the 3 drug combinations, and I heard loud and clear from the previous speaker, it has to work, but it also has to be financially sustainable. So I guess I break the bank a little bit here when I kind of talk about KRD with daratumumab. But I think you could argue the other way around and say if it works for a long time, versus if you have to stay on therapy for a long time, well, you do the math. I don't know. Maybe expensive short-term versus less expensive long-term should be the future discussion. I don't know. We can talk about that. I think DARA obviously is added to a lot of therapies, and we heard from a previous talk that it seems to be very safe and it can increase efficacy. I think with better therapies, we see higher rates of MRD negativity. And I think with better assays, better drugs, it's very likely that we will start seeing, in my opinion, MRD-driven treatment strategies. I think a huge need going forward, this is the last bullet on this slide, is to define MRD negativity in newly diagnosed patients just with these new therapies and not starting to add in a lot of the old stuff. So without the transplant, just say, how good are these therapies actually? Because when we start adding in everything, then it becomes difficult to see how good they are. And I think a lot of the trials out there include a little bit of everything, so it's hard to see how good they are. So we set our hypothesis to see if we could use a modern quadruplet and target 60 to 80% MRD negativity, and to determine MRD before any transplants are done, to not blur the water. You can do transplant afterwards, but we wanted to know how good they are. So I showed this at ASH in Orlando. This is a phase 2 study. It has not yet been published, so what I share with you today is the information from ASH. 41 patients included in the study. You see average age 57, a little bit more females. 49% are high risk in the study, half the patients. And when I presented, 30% had been evaluable for the primary endpoint, which is MRD negativity after up to 8 cycles. The primary result was pretty strong here from ASH, 77% MRD negativity. That's a pretty good deal. And you see the CR, VGPR, and overall response rate. And if you look in those patients for the data cut for ASH that completed all the 8 cycles, the results look very similar. I can share with you a secret. I'm writing up, hopefully next week, I will have the draft written up and the results look very similar in the final version of the paper. So here you have swimmer's lane, and after completion of 8 cycles in dark green is MRD negativity. You have again this 77% MRD negativity. None of the MRD negative patients have progressed. When we look for toxicity, there is no new grade 3 or higher when we use the weekly quadruplet compared to the bi-weekly KRD. We don't see that. There is no grade 3 or higher neuropathy, no death on study, and the dose reductions that we see are, for the vast majority of cases, in lenalidomide and in dexamethasone. So 77% MRD negativity just with these modern drugs together without a transplant. The dosing we give here is 27 infusions. The median time to MRD negativity is 6 cycles, and there is no added toxicity compared to twice a week KRD. So this is not a randomized study we're looking at. These were 3 different studies, so be cautious. This is cross study comparison. I think the rate here of MRD negativity in the Griffin study, VRD 6 cycles with the transplant, I think is quite weak, 20%. VRD with daratumumab with the transplant, much better, 51%. And then you have KRD for 8 cycles from the Forte study and the transplant, 58%. And KRD for 12 cycles and no transplant, they had 54%. So to me, this like a little bit mimics what the previous speaker talked about. You can add an antibody or you can play with a better proteasome inhibitor and see a little bit similar responses. Or you can do a better proteasome inhibitor and add the antibody. And that's when we see a better outcome in terms of MRD negativity. And there is no transplant in this. So this has also triggered us to develop a larger study. And we have already opened the ADVANCE study. The ADVANCE study compares 8 cycles of KRD daratumumab with KRD without daratumumab and VRD. And MRD is the primary endpoint after 8 cycles. If patients are MRD negative after 8 cycles, they will keep their stem cells and go right to maintenance for 2 years on the protocol. If they are MRD positive, they go to a transplant and then they go to maintenance. Importantly, the transplant will not be forgotten or hidden. It will count as an event. So event-free survival will be a secondary endpoint. So unlike the endurance trial, where you could transplant or change to different therapies and not mention that as an event and censor patients, this study would count that as an event. So to wrap up my perspectives on myeloma care today and tomorrow, I think use the best available therapies right away for all patients in a newly diagnosed setting. Disease biology and treatment obviously will dictate the outcomes. And therefore, I would say that high-risk disease is a moving target because we get better at defining the biology and the treatments are always getting better and evolving. So it's a moving target. Be careful with IV fluids, do cardiovascular workup when you use modern PIs such as carfilzomib. In my hands, I give 250 milliliter of saline before the first dose of the first cycle. And after that, I don't give any IV fluid at all. And I don't see any congestive heart failure, literally. I do EKG and echo on every patient before I treat them. If I see something there, I don't use carfilzomib. I would use bortezomib. If available, I would use MRD testing to gain prognostic information. And I think MRD testing in the future will hopefully soon have a role in treatment decisions. We obviously need to build more data to feel more confident in that. But in our practice, we have already started playing with this. And the last slide here is the relapse refractory. I think the earlier relapses, when what I mean with that is the first and second relapse. I'm not talking about a quick relapse shortly after. I'm talking about the first and second relapse. I think it's not that different. I think the first relapse could be treated in a similar way. Again, use the best therapies. Consider reusing drugs that worked in the first place. I think maintenance could be used again. I use maintenance for patients in their first relapse. I give the best drugs again. I check for MOD and put them back on maintenance again. We see high rates of MOD negativity in these relapse patients. And I think MOD could have a role there as well. And maybe also step up therapy again if there's a new occurrence of MOD positivity. I would like to thank all my collaborators here in New York, or external collaborators, or funding support. I would like to thank you so much for your attention. And the very last slide I show you is that I'm actually moving from New York to Miami. So come and visit me in Miami. I'm going to start there in November, and I welcome you to come and visit me. You cannot come all at the same time, but you're welcome to come anytime. Thank you.
Thank you very much, Dr. Langren, for that excellent presentation. Not a single person has logged off in this last 40 odd minutes. So that's a testament of how absorbed people were with your presentation. So thank you very much for that.
Thank you.
Perhaps we could start off with one of the burning questions that has been posted in the group. So let me just pick that up. So this is Stella Chai asking, since we do not have head-to-head comparison of KRD and VRD in the high-risk newly diagnosed multiple myeloma patients, I think she's alluding to the fact that endurance study excluded the high-risk patients. How do you view these two regimens for high-risk newly diagnosed myeloma patients? Maybe I'll ask Prof. Landgren to take that question.
Well, I think that in the absence of data from large studies, it all boils down to our clinical experience. Maybe I should give as a disclaimer. So our program here in New York, in 2019, the myeloma program had about 10,000 myeloma outpatient visits. So we have a quite big practice here in New York. In my hands, I think that the KRD regimen is superior both in the high risk and the standard risk patients. When I read the endurance trial, I think there are many problems with that study. If you look at the PFS that's reported both for VRD and for KRD, it looks to me very similar to what I showed for the SWOG study for the RD group. For some reason, the PFS is just not really in line with what we see. I don't know why that is. If you look at the trial, patient stopped treatment, both VRD and KRD, after just a few cycles, 2 or 3 cycles. So they didn't get the therapy. When I looked at the supplement online, I see that over half the centers that participated in that endurance trial enrolled 1 or 2 patients. So I wonder if there is lack of experience giving these therapies, and that patients therefore not were treated the same way that they would be treated if they came to a center with more experience. So I think those results are very, very difficult, troublesome. So I don't really see how that helped the field going forward. I think the KRD regimen is superior in my hands. And I think there are a lot of other studies. Andrei Jakubowiak has published, the French has published, NCI has published on KRD showing good results in both high and standard risk patients. But we have a large randomized study now published. So we will have to live with this and deal with it. But I think that the interpretation and the attention to detail is very, very important when we look at trials. I think that trial has so many problems.
I think I would completely agree. I think it's primarily a community oncology practice-based study, which is an important thing to remember.
And if you look at the side effects they have there with the shortness of breath in the study, with the IV directions, they have given in the protocol. They recommend to give 250 liter of saline before each dose and also after each dose, and it's twice a week. So that's actually 1 liter of fluid. So if you give half a liter for each dose, so it's 1 liter per week. So with 8 cycles, I mean, you're basically giving a patient the same amount of IV fluid as you have in one of these huge tanks you have in a water tank you have for water in your cafeteria. I'm not surprised that you run into problems if you give so much IV fluid.
Sure. I don't see any other questions coming up at the present time. So maybe we'll open up the panel session and they'll, I'll bring in the other 2 doctors amongst us who are sitting quietly in the background. So I'd like to welcome Dr. Daryl Tan, who again needs no introduction to Singapore, Malaysia, and Indonesian audience. He's one of our predecessors in SGH and has led a lot of trials in SGH. And last but by no means the least, Professor Chung Wee Ju, who again needs no introduction to any of us here. He's our leader. He's the leader of our group. And we all look up to Wee Ju in terms of myeloma, and he's firmly put Singapore and the world myeloma map. And please join me in welcoming both Dr. Daryl Tan and Prof. Chung Wee Ju. So we'll go on to the panel discussion session. And I've got a couple of points to note here. I'll come back to the local perspective maybe in a few minutes down the line. But I quite like your idea in your presentation. You know, can we really have the ability to tease out who are the poor risk players upfront? Is it fair enough to just do that? But if we extrapolate what happens perhaps in other diseases in hematology, for example, the way Hodgkin's lymphoma has gone, you know, you do have some kind of prognostic factors, be it clinical, a combination of clinical and genetic factors and so on. But then you need something that is more dynamic. The question is, you know, whether we are okay with just using, with at the present moment, till a few years ago, we were just using the upfront strategies that we were using in terms of FISH or cytogenetics or whatever. Now with the MRD, we are now coming up with the more dynamic assessments of how disease is behaving. So how do you see this going? I mean, MRD, we can discuss a whole day on what are the pluses and minuses of it, you know, what techniques to use and so on. But how do you think, is both the upfront and the MRD alone enough? Do we need to optimize any of these things in addition? And if so, how do we do that? You know, it's a big conundrum. There is no one clear answer to it, but maybe I'll start with Wee Ju here. You know, what is your thoughts on what is high risk? What is high risk in your mind?
Well, actually, you know, in real terms, right, you only know whether someone is high risk when they die within, you know, like 3 years, right? I mean, that is high risk. And I think at the moment, what we have are a series of factors that allow us to approximate that. But I would say that it is not a perfect system, right? And that is the challenge. And as I explained in one of the recent session, we still have today patients that doesn't appear like high risk with all the kind of upfront factors that have available to us. But once you start the treatment, they have very refractory disease, very aggressive progression, early progression, difficult to salvage, and they die within a short time. And so we still can't identify those patients, although I must say that with the additional genomics and additional information, that group is probably becoming smaller and smaller. So I guess we're getting closer to where we need to get to. And then in truth, also the response is a very important factor. So we know that for so-called high-risk patients, the achievement of MRD negative become even more important. But here is another set of questions, because we also know that there is a small percentage of patients, maybe 5-6%, that can go on with small amount of residual disease, MGUS-like, that can be quite happy for a long time. And in those patients, if you treat them aggressively to try to get them to MRD negative, you may actually do more harm than good because they may get toxicity and so on. So I think in myeloma, we still have these, what I call the end of the bell curve, the 5% at the end, that we perhaps unable to get to. But I think for the 90%, majority of them, I think we, with the current available techniques, we have a fairly good handle on. But then the question is, what is the optimal treatment for them? So I was intrigued by the very high MRD negative rate that Ola managed to get with the DARA KRD. But I wonder whether is there a difference in your high-risk population versus your standard risk? You didn't quite go into that detail. And also whether sustained MRD is actually a much more important endpoint, because we do know that if you lose your MRD quickly, those could be the bad players as well. Yeah, so that's my thought on this.
Daryl, anything to add from your perspective?
Right, I like what Viju said. I was quite impressed by the DARA KRD data. Similarly, at ASCO this year, the data from the concept trial, the German study by Katja Weiser, showed that with ixekizumab, with KRD, you get very high MRD negativity rate. So I can't wait for the data of phase 3 studies to pan out, because all these phase 2 studies are all looking so good. But the only shortfall with the upfront KRD data that has disappointed everyone is still the Forte study, where patients with high-risk disease, if they did not undergo a stem cell transplant, they ran the risk of an early relapse. So it begs the question, will the addition of a monoclonal antibody prevent that early relapse? Yeah, I'm waiting for studies to see if these kitchen sink approach front, we still need a randomized trial to inform us about the role of a stem cell transplant. But nonetheless, for my high-risk patient, yes, I do agree with Ola that for want of not knowing anything better, I will still try to incorporate carfilzomib into my frontline regimen for patients with high-risk disease.
You've actually ventured into some of my second and subsequent questions there, but I'll leave Ola to answer the key question there. In our setting in Singapore, still transplant is a very big part of the management. Part of it is economical, I understand that, but part of it is also the data that we have, not just in the Forte that Daryl was mentioning, but also we haven't managed to show that it has never been shown to have been of any inferior outcome in any group of patients with any induction regime. That's the bottom line. It does come up time and again that every time a patient goes through whatever induction they go through, plus a transplant, their progression-free survival is always better. And there are a proportion of patients who definitely benefit and stay in a progression-free state for a much longer time. Yes, there are a proportion of patients who are going to relapse after that, which are probably the group of patients who bring down that OS, hence the transplanted patients are not getting an OS benefit. But how do you reconcile the fact of not transplanting? And I know the practice in US has moved a lot away from transplant and upfront situation in several parts of US, but how do you reconcile that fact?
Well, I think these are great questions. So first of all, before I answer that, I would like to say I really enjoy Viju and Daryl's aspect. I share very similar ways of thinking. So coming back to your question, how do we deal with this transplant? I do think that there are many details here. So one thing is the healthcare system, as you know, in America is very different from the healthcare system in Singapore. So in America, if you have a job, you have an insurance. And if you have an insurance, you want the best for yourself. So that's like the principle, and that's the American mindset. If you cannot work, then you may lose your insurance. So a transplant means that you cannot work. So that's a problem. So you put your whole family at risk. So if you say to the patient, you won't be able to work for many months, many patients say, what did you say that therapy was? Do you have something else? So that's like a big problem. Now, if you're over 65 years old, America has actually not that very different from my clinical and practical experience. I'm from Europe, from Sweden. In Sweden, they have the social medicine or universal medical health care. Here in the US, when you're almost 65, you have Medicare, and Medicare pays for everything. So once Americans turn 65, they have access to basically pretty much European-like healthcare to a very high degree. People forget to mention these things. So I think the people that are younger, that are working, it is a big problem to not be able to work because your whole life is kind of linked to that, your family, everything. So that's a problem. And then I think also the fact that healthcare here is so linked to your work. I don't know all the details of what it's like right now in Singapore, but people here behave, to me, is very similar to if you drive your car and you have an accident, you want that car to be fixed to the same degree as it was before, or you want a new car. You don't want an old car of another brand. You want the same. So if you paid all these dollars, you want the best therapy. So patients are also asking what I showed you here. I have patients that come to New York, they say, I want this DARA KOD. I saw ASH. I was online. I saw it. I want it now. Well, so it's not yet approved. Well, I want it. Okay, I'm going to call the insurance. Okay. And I have patients, they actually talk the insurance into approving it. So this is the American mindset. People want the best. And to some degree, it's of course best based on their own interpretation. And they may not be doctors. Most of them are not. Then the disruption. So I think those are important different aspects from my European background. None of these things I would see in Europe ever. And then I also think that another reason why I think I, as a clinician, still feel very comfortable doing what we do is because we have such a large program. We have treated so many patients, and we have, based on faculty discussion, concluded that in the absence of a randomized phase 3 trial definitively answering this, we basically have two options. Either we have to deal with all these difficult patients that come and tell us what to do, and we get frustrated every time, and we sit and wait for the phase 3 data to come out in 10 years, or we just deal with it. So we decided to deal with it. So we decided to say to the patients, okay, let's talk about this day one. We don't know. No one knows, but it is probably reasonable to do delay if you're MRD negative, because we don't think you're going to live shorter, and you will always have it as a backup. You may have a shorter PFS, but it's your decision. We think if you're MRD negative and your standard risk, there probably is no difference. And for high risk, there may or may not. But you're not going to probably live shorter. So if the disease comes back, we can do it later. And we felt that was a reasonable approach to involve the patient. Every patient see a myeloma specialist. Every patient see a transplant specialist. And I can tell you lastly, after having done this for 7 years, the data doesn't look different internally in our databases. But none of us can walk up on stage and put the p-value on our t-shirt and say, I know the answer. You have to publish the study, right? So that's the problem. But it doesn't look that different.
Okay, thank you very much for that comprehensive answer. Before I go on to the next question, I actually made a case study presentation to lead into the next discussion. Do you think we have time? I mean, it's 8:08 now. It'll probably take about 3-4 minutes for me to finish the presentation. Should we go ahead, or should we just go through the questions?
I do have a hard stop at 8:25 my time, but you decide however you want to use the time, and if you continue after me, that's fine too.
Okay, maybe we'll skip the case presentation. I'll go to the next thing that I've got to kind of, understand a bit more and want your opinions on. So one of the questions that often comes up in my mind is, whether it is upfront first line or second or subsequent lines, which PI do you choose? Which proteasome inhibitor do we choose, particularly in high risk multiple myeloma? And we kind of alluded to in the discussion of endurance study of KRD versus VRD. The second question is, what is the best partner? Now with also the advent of daratumumab, and from what you say, from Ola's comment on how the American practice is, it might be a bit of a moot point asking that question because you want all 4 drugs, not just 3 drugs. But if you are thinking, what PI, first generation or second generation, what is the best combination? Is it daratumumab, a CD38 antibody, or IMiD-based combination? Which one do you think is going to work? I mean, assume for a moment that you're not having the luxury of using all four of them together. If you had to choose between an antibody and an IMiD combination, which one would you choose?
Is that the question to me or to the panel?
Maybe I'll start with Yunsen, who's not in the picture.
Oh, sorry, I am in. Okay, you gave me a hard question. I personally have no experience comparing them back, like DKD versus KRD, but.
So it is clear that you're going to choose carfilzomib over bortezomib.
Yeah,
okay,
definitely.
All right, fair enough. No bias there, yes, okay.
Yes, no bias there.
Daryl, maybe?
I'll probably look at the age. My preference will still be using bortezomib for most patients, but for patients with high-risk disease, I will want to consider carfilzomib. As far as possible, I will still want to stay on label with all my prescriptions, especially the older patients, because of we've read the disasters with the KMP data. Slipped my mind the name of trial. Yeah, so I mean, for older patients, I try to shy away from carfilzomib upfront. I'll keep that as a backup when they relapse. That's for older patients, but otherwise, young patients, high-risk patients, although earlier on there was a question on endurance not having patients with high-risk disease, but if you look at a subset analysis, there seems to be a non-significant trend for patients with stage 3 disease and cytogenetic abnormality benefiting from carfilzomib. But overall, I mean, I do agree with Ola that with high-risk disease, I think my personal experience is that it's a more potent proteasome inhibitor. But generally, my preferred PI is still bortezomib, but I always want to combine a PI with an IMiD. Maybe from my bias of the IFM data, I try to shy away from an alkylator as far as I can. In my practice, most patients do not have issues with lenalidomide. And I mean, even those who do, they know where to get the generic lenalidomide across the border. But now with COVID, it may be a little bit tougher. But as far as possible, I want to combine PI with an IMiD upfront.
So in most of your answers, you've obviously used newly diagnosed myeloma as your index patient, right?
Yeah. Mm-hmm.
Yeah. So maybe we go to Viju next.
Yeah, I think very similar to Daryl. I think if you look at the potency for sure, I think carfilzomib is a more potent proteasome inhibitor. But again, in vitro potency doesn't always convert to necessarily a huge advantage clinically, and there are many factors involved. But in high-risk patient, I really do believe there's a role for carfilzomib, even in the upfront setting. And then, really currently we don't have any phase 3 data comparing, combining DARA with carfilzomib in the upfront setting. But the data from the CANDOR study is very impressive as well in the relapse setting. So there's no reason to suspect that wouldn't translate in the upfront. But we constantly get surprises, right? So endurance study, nobody expect that result. So I also would say that, really the proof is in the pudding. There is still validity in having phase 3 study. But I think in high-risk patient where we clearly know that, you need the optimal treatment, I think these combinations definitely have a role.
Okay. Before I go to Ola, it is only fair that I put my comment in as well. So let me just put the comment in. So I was just thinking, I think about this all the time. There is a degree of restriction of the dose of carfilzomib when we combine it with IMiDs. And I wonder about that all the time. When we were able to give, so one of the first few things that we observed in our study, in the MM1 study, was when we went beyond the 36 mg per meter squared, patients started getting, TMAs, thrombotic microangiopathies. And it was around the same time that Kui Yong in UK was also running her MUC5 study. And she was liaising with us too. And she has pretty much similar experience of going beyond 36 and then patients developing thrombotic microangiopathies. So this is it. When we are able to use carfilzomib beyond the dose of 36 mg per meter square, which is typically the Candor dose or even the Endeavor dose, for example, in a relapse situation, albeit, it seems to be much more effective than when it is used at 27 or 36 mg per meter square. That restriction does not come into play when you use a daratumumab or an isatuximab, for example. But when you use an IMiD, that is when problems come, or even an alkylator, for example. So do you think, when you are not able to use an antibody, you are potentially running into problems in delivering optimal dose of carfilzomib in particular? Is that a problem? Do you see that as a problem?
I think these are extremely important aspects you bring up. I'm a true believer of details. I think one of the reasons I think that VRD in the endurance trial was not different from KOD is probably, in my opinion, because KOD I think is a little bit more difficult to give. You can run into more problems. And if you have these sites, if half the sites treat 1 or 2 patients, that's a problem by itself. So all these things you bring up, I share with you what we would do. So I think it starts with the fluid. So actually it starts with the workup, echo and EKG. If you have problems there, don't do carfilzomib. The second is the fluid. Give much less fluid, that's both in the packet insert and for sure in the endurance protocol. Don't give half a liter of fluid every week. If you have a randomized study where you just give fluid versus not, you're going to see more congestive heart failure if you have in the general population. You can do that study. I bet $100 that you will see more congestive heart failure if you just give IV fluid. So don't do that. So if you give 250 cc of saline before cycle 1, day 1, and stop all the IV fluid, that will really be important. Then when it comes to the dosing and the infusion rates and all these other things, I would give it for half an hour. I would not do 10 minutes. I would always do 30 minutes. I think the avoidance of problems with cardiovascular or thromboembolism also comes down to how you prophylact your patient. I no longer give aspirin. If you give aspirin, you run into a lot of DVT with some of these powerful therapies. And if you give, it's not particularly unique to one drug, it's just powerful therapies induce a lot of cytokines and you run into a lot of problems. I have switched the whole practice, our entire program. We give oral factor 10. We give Xarelto, 10 milligram once a day prophylactically. And that takes away all the problems with thromboembolism that we used to see. We saw up to 20, 30% DVT. We don't see that anymore, it's gone. That was a huge shift. So I think echo, EKG, optimize fluids, give oral factor 10. It's like a different ball game in my experience. What dose do I like? So I know Amgen sells the drug by the milligram, so they like more milligrams, but I don't like 70. I like 56. I've talked about this many, many times. I know it's approved in 70. I think 56 is a very good dose. I give 20 milligram per meter square day 1 of cycle 1, and then I do 56 milligram per meter square day 8 and day 15. To me, that's a very, very, very good dose. It works well, it's very well tolerated. I used to give 36 milligram per meter square twice a week, but now I do 56. Your question about IMiDs and other options, if you go over 56, that's when you start seeing in the studies that have been done, and I know some of you guys, and I have been involved in some of the early phase 1s, if you go into 70 milligram with IMiD, that's when you start seeing bad things happening. 56, you don't. You can go over 56 with DARA without seeing the problems, but in my hands, you still see patients suffer from fatigue and there is more hypertension. So why would you have to go there? So my argument would be pick 56, do that every time. And the worst that could happen is that you may end up giving 1 more cycle or 2. What's the big deal? It's just easier to give, it's more well tolerated. It's just a very, very robust model. But I think oral factor 10 and optimized fluid, those are key things if you want to be successful with these therapies. Otherwise, you run into problems. So these are my 2 cents.
I think most of those points are probably my, things that I keep in mind as well. I like 46 mg per meter squared twice a week, and I almost never eat to the request. And the case presentation, if I had the chance to present, it was exactly to state that kind of a point. The patient pressed and pressed because of her, keenness to go on cruises. So this is a lady who always wanted to be on a cruise holiday, and she, requested time and again, every line of the therapy all along her way to try and minimize the number of days that she needs to be in the hospital. When I got to her second relapse, Daryl may know this patient, we share the patient. Whenever I suggest a change in therapy, she goes to check with Daryl if I'm doing things right. So, finally, she went on to receive carfilzomib, and 2 cycles into it, the light chains came down, and immediately she wanted to switch treatment to once a week. And I did, and not surprisingly, the light chain started going up, and I really had to sit her down and say, listen, we've got probably the final bite of the cherry in terms of giving you a long PFS here. Can we just persist with this twice a week dosing? And I'm going to add daratumumab. And that I did, and I don't regret it. It's about 14 months now. She's on Dara Carfil Dex. And for the first time ever since the newly diagnosed situation for her, which was in 2016, we are now in 2020. For the first ever time, she's not only in CR, but she is also in MRD negative state. So, my strong belief is using a stronger PI like carfilzomib and not stopping it is probably one, practical way to keep high-risk patients in a progression-free state. It definitely is not going to work for everybody. You've probably got one of the better options with that.
May I insert very briefly one quick thing that I forgot to say that I also think is important I have seen in my practice. I do think that there is an interaction between the biology and the amount of residual disease. So I have seen patients who have some of these nasty signatures genomically, but if you really drive it down to low levels, it doesn't become much of a problem. But if you leave a little bit behind, that's when it's a problem. So I think there's probably also a threshold, and that also comes back to the clinical aspect. I think when people think about maintenance, many times I use single drug maintenance is because I'm kind of aggressive upfront and I determine MRD negativity, and then I switch to single drug. I think if you're less aggressive, you don't look for deep response, you're stuck with multi-drug continuous therapy. So now we're talking about cost. I do single drug maintenance. I'm a very cheap date when it comes to the long term, but I'm expensive when it comes to the appetizer, I do very expensive appetizers, but then I'm a cheap date.
I think that's one of the points that we are, that we are specifically raising in the manuscript that we're going to submit from our trial, is the ability. So which PIs can you deliver in the longer term? Bortezomib is out beyond first few months because you develop neuropathy and you can't continue to deliver that. Ixazomib is probably a relatively weaker PI that by itself is not going to produce a long, response, continuous response. So carfilzomib, I believe, is a good drug chosen for maintenance, provided the patient doesn't have toxicities. You keep going, and once you have achieved a good MRD negative state, it's probably a very good drug to keep the disease down. Right, okay, so we have the last 2 or 3 minutes. So a quick fire question on local perspective for everybody. And I'll start with Yunsin again. So what do you think is a practical strategy for management of high-risk multiple myeloma from tomorrow for Singapore?
So I think the achievement of MRD negativity and trying to prognosticate all these high-risk patients, selecting the ones whom, like you all said, depending on the patient's fitness and all, to actually go all the way out and driving them down to very deep levels of MRD negativity. So select the proper patient, give them the best treatment available up front. Like Prof. Ola said, you use a very good appetizer and you drive down the very good response, and then hopefully it stays that way. So I think in the correct patient profile, carfilzomib can attain that kind of deep responses. In other cases, I mean, there are some cases whereby even if you choose something and after a few cycles you do not see such a good response, you can always convert and try and get them down to MRD negativity. And of course, transplant is still a good option. Yep.
Yeah, sure. Yes, absolutely. Daryl, do you want to go next?
Oh, no, I certainly agree with Vincent. The first bet is the best bet for high-risk patients, and I would be very ambitious in trying to drive the disease burden down. Not just to drive the burden down, but also to, wherever possible, with a quadruplet to actually suppress clonal evolution if there's a possibility in doing so with the various agents. That's what I'll do. I mean, I go heavy up front, and if a patient makes it does well, that would be good. And certainly transplant is something that I will not, I probably will not defer the transplant option for such patients, even if they're MRD negative, because from all the various studies, I think there is probably still a role for transplant at this moment. Yeah, the kitchen sink approach for high-risk patients.
Okay, 2 kitchen sinks so far. Viju?
But kitchen sink, I also agree with. I mean, for high-risk patients, you just can't really mess around with them because we know, I mean, all the other treatment we've been given are not really effective. So in this particular case, although there's no phase 3 data, we'll go with carfilzomib, and maybe, you know, for those who can afford rich insurance covered, I will go with Ola's regimen to get 77% MRD negative rate, you know. And I think in the high risk, achieving MRD negative is really important. So you will go with consolidation, you know, and try to really get them there if you don't yet achieve that. So I think that part is important.
Okay, thank you very much. I think because this is a very local perspective question, I'll spare Ola of this question so that he doesn't need to answer. So thank you very much for all your participation, and thank you very much to all the attendees as well of this meeting. Do remember to fill in your feedback forms as you sign out from us. So thank you once again from SingHealth Duke-NUS Blood Cancer Center. I believe Dr. Aloysius Ho is still on the line. I'm not sure if he's still on the line. Do you want to say a couple of words, Aloysius?
Yes, I'm still on the line. Thank you, Mauli.
Thank you. Thank you.
That was a very, very interesting, very useful session. Myeloma certainly has moved on from the days of melphalan and prednisolone, which was actually very cheap, but didn't produce much results. But once again, thank you, Prof. Langren, for spending your Friday morning with us. And thank you to the panel and to the participants and to Amgen for supporting this meeting. Yeah, thank you very much. And we look forward to hosting more of these events.
Thank you very much for having me.
Yeah, thanks, everyone.
All right.
Welcome.
Thank you.
Thank you. Take care.
Take care. Take care.
Bye.
Bye.
Bye.